Okay, thank you all for coming through. I think the audience online are already there, so it gives me great pleasure to introduce Dr. Russel Drummond. Russell is my go-to endocrinologist. He made a mistake a few years ago. He gave me his mobile phone number. And so I am frequently on the phone to him with complex endocrine problems that I've just not got the brain power to cope with, but fortunately he has. He works with me. He's out of North Glasgow, works in Stob Hill and Glasgow Royal Infirmary. And I'm really looking forward to this talk. So, Russell, thank you very much.
Pleasure. Hey, make sure I can see you all. So yeah, I've worked with Omar now for 14 years, and then previously as a registrar. The first time I ever met him actually was in Resus. Omar remembers, but he'd come down because there was someone with stridor who couldn't breathe. No drugs would work, and cold steel was required. I'm always jealous of surgeons. So are you all surgeons? Yeah, because at least your parents know what you do for a living. Whereas my parents have got no idea what an endocrinologist is. So I'm going to go through medical management of an overactive thyroid, kind of focusing quite on what causes it, the treatment options and how things have changed. So in a talk, you say the same thing 3 times. And the thing I'll say again is that in terms of medical management, we haven't been giving antithyroid drugs for long enough. So a 12 to 18 month course, which is what all the textbooks still say. And if you ever look at the Oxford Handbook of Diabetes and Endocrinology, it still says in there the average patient requires 12 to 18 months. Whereas there's more recent data that shows that actually longer courses are much better and are far more favourable. So if you need any reviews on thyroid disease, and there's 2 good ones from the Lancet and the Lancet Diabetes and Endocrinology in the past 12 months, and they always talk about patient preference for treatment. So is there anyone here who developed primary thyrotoxicosis? Would your first who'd opt for antithyroid drugs? Yep. Who would want radioactive iodine? And surgery? Marvelous. That may change, but I doubt it. I'm always slightly, so I give a talk on diabetes and I always mention the fact that 1 unit of insulin is named because it was the amount of insulin required to give a rabbit a seizure in 1922. When they're trying to work out how to measure insulin. And I always worry that I go through all these things about diabetes and that's all anyone says. And then when at the end, you can say, rabbit had seizure. And I'm always slightly, so I gave a bit of this talk to some medical trainees from a different aspect. And one of them a few weeks later said, I can't believe the hamburgers. Anyway, so thyroid disease is really common. I won't go through all these. And in terms of hyperthyroidism, whether or not you're in an iodine deplete or an iodine replete part of the world, it goes from like 0.5 to 2% up to 10% of people. So although we think thyroid disease is common in the UK, it's much more common in other places. There's elegant studies from Denmark looking at different iodine contents in different parts of Jutland. If you ever get bored, I'll start with the case, which will, and the reason for this is because it illustrates bits and pieces of my talk that I'll come back to. I've got another case at the end if we've got time, which just shows how I don't think if a doctor gives a talk and starts off with, I got referred to this patient from something elsewhere, what a mess it made. Luckily, I was around. Mine's is the opposite. This is a case looked after, and actually the patient made the diagnosis in the end. So I was asked to come to our haematology day ward, which is just below the ward I work in. This poor guy who's 22, who's had teenage Burkitt's lymphoma. He'd found this reactive lymph node under his left jaw, and we thought, oh no, it's come back. So the haematologist was brilliant, phoned me and said, I think he's thyrotoxic. So he'd lost a stone in weight. He had a moderate goiter. There wasn't any bruit, no evidence of thyroid eye disease, but he had a fine tremor. He had classically thyrotoxic biochemistry and some of the other associated things that we see with someone who's hyperthyroid. So a slightly low white count. So moderate leukopenia is present in patients with thyrotoxicosis, and a slightly high calcium, but not too high. And his T3 was over our reference range. He had no partner, he had no plans to conceive, lived with his mum and dad. His dad had come up to the clinic with him, expecting bad news that this may well be Burkitt's lymphoma and a biopsy would be required and perhaps more treatment. One sister was 28, and he had some mild childhood asthma. And he had a viral upper respiratory tract about 2 weeks ago, hence the node. And so the question is, well, what's causing it? And I put up the most common causes. But obviously he's young, so you think about Graves' disease. And in terms of investigation, so this is all bits that we do, but I say to people, there's only 2 tests that you need to do for patients with thyrotoxicosis to work out what the substrate is normally. Although I'll come on to the rare, the weird, and the wonderful, and the hamburgers, is you measure their antibodies, and if they're negative, you organise an uptake scan. If the antibodies are positive, don't organise an uptake scan, certainly don't organise an ultrasound, because then you'll enter a whole world of incidentalomas that really don't need to be investigated and cause chaos, concern, and unhappy patients. So measured as antibodies, thyroid receptor antibodies, strongly positive, and TPO antibodies. So TPO antibodies, they're a marker of autoimmunity. So they're present in people who will develop autoimmune diseases of any kind, particularly Hashimoto's thyroiditis. But thyroid receptor antibodies are what cause Graves' disease. And started him antithyroid drugs. He had no inhaler for years, so I gave him some propranolol and said, if you get wheezy at all, don't take any more. Other drugs are available. So he and his mum, he and his dad said, if it is Graves' disease, how long does he need treatment for? And they'd known someone who'd had an overactive thyroid, and it went on and off. So, how long do you give it for? Are there any other options? So I spoke about radioactive iodine. So he actually is now on 5 milligrams of carbimazole. I was at clinic last Thursday, and I'll come back to thyroid receptor antibodies in a bit. So where the thyroid gland is. The function of it is very, very clever. So iodine is actively transported via the sodium iodine symporter, then secreted out through pendin, which is a mutation of which causes something called Pendred syndrome, which causes hypothyroidism. It's oxidized into either monoiodotyrronase or diiodotyrronase. A DIT and an MIT make T3, and two DITs make T4, and the thyroid is the only source of T4. And anyway, so importantly to come back to later on is this enzyme thyroid peroxidase, and that's the enzyme that we inhibit by giving antithyroid drugs. If you ask most endocrine SPRs how do the drugs work, they won't be able to tell you. They'll have learned about it for their exit exam, and then these things come and go. It's like learning a phone book. The thyroid is involved in almost all cells in the body, and very important in development. We monitor women who are pregnant through each trimester to make sure they're adequately thyroid replete. If patients are hypothyroid, and they're on treatment, when they have a positive pregnancy test, or as we say in Glasgow, if they fall pregnant, then they increase their dose by 25 micrograms. And if they don't, then you worry about fetal development. I've got one slide on hypothyroidism because I know that's an important issue with you once the thyroid gland has been removed. T3 acts as a nuclear receptor, and I'm always amazed that the amount of free T4 and free T3 is actually vanishingly small because it's such a protein-bound phenomenon. So that small amount of hormone that pays a percentage of my mortgage is very important. And there's a huge amount of manifestations that you'll all be aware of that I've put up from this review from the Lancet Diabetes and Endocrinology. And the kind of 2 things I would say are patients who are thyrotoxic feel terrible, really bad. The tremor can be really embarrassing. I had a painter from Celtic Park who asked me to write down his diagnosis so he could show Neil Lennon, who's manager at the time, because his nickname was Jakey, which is the Glaswegian term for alcoholic, because he was turning up tremulous. Up and down ladders, painting green and white stripes every day. It's brutal. So they feel terrible. And that's often why patients, the thought of having a recurrence or a relapse is absolutely devastating to them because they remember how terrible they felt. Everyone loves the weight loss. And there's some permissive concordance for many of my patients who, because they regain the weight that they lost due to their thyrotoxicosis because they were eating too many calories. And so when they regain it, they sometimes drop a few days here and there. And I can tell when they come back to clinic and their TSH is still suppressed, that you've not been taking the adequate dose. 50% of men have sexual dysfunction from a recent study, and then periodic paralysis can happen, particularly in Asian men, which if we've got time, I'll come back to. So as I said, thyroid function tests, they're toxic, what do you check? They're antibodies, and if they're negative, an uptake scan. And I've got some examples of an uptake scan. you can break it down into the etiology, and I've only put this up because it shows that how much of the, so this is from a large 1,044 patient cohort study, so it's these numbers. So there's vanishingly rare things, but the common things are, so Graves' disease due to TSH receptor antibodies. Between 1 to 5% of people have got antibody-negative Graves' disease, but you'll diagnose that on an uptake scan. There's a phenomenon called transient gestational thyrotoxicosis, and that tends to happen between 13 and 15 weeks of pregnancy. It's because there's homology with beta-HCG and TSH. So at that point in pregnancy, you've got 50,000 international units of beta-HCG, and the TSH receptors, well, I'm not fussy, I'll take you. But that just requires, it typically occurs with hyperemesis gravidarum, and that just needs fluids, antiemetics, and occasionally beta blockers, no antithyroid drugs. A toxic multinodular goiter, as you'll know, is more common than a solitary nodule. These are ones that will require definitive therapy, but we have a lot of patients who maybe they're elderly, they're not good surgical candidates, so I never send them to OMA. And long-term low-dose antithyroid drugs are perfectly safe. I work in a part of Glasgow where postcodes have an average male and female life expectancy of 54 and 57. So if I get someone who's 65 or 70 and they've got mild thyrotoxicosis, that's well-managed antithyroid drugs, they don't always need to go for radioactive iodine therapy if they've refused that, and they don't need a thyroidectomy if it's controlled on medication. There are rarer causes. So a lot of people like the fact that they can take some extra levothyroxine to reduce their weight or keep slim and trim, or they feel that I'm tired, it must be my thyroid, and they increase their dose. I'll get back to it, but actually the levothyroxine's got a very narrow therapeutic index. It's very easy to work out what someone's levothyroxine dose should be. But if they take too much, then it can have long-term effects on osteoporosis and your cardiac function. And yes, there's a hamburger, so hamburgers that contained neck meat with thyroid tissue caused an outbreak of thyrotoxicosis. And I've yet to diagnose it in Glasgow, but I've been looking for it keenly. And then there are rarer, more concerning things. So Struma variae, I've seen one case of that, and that's when they're thyrotoxic, their antibodies negative, and their uptake scan is black, so it's coming from somewhere else. And that's when you think about very rarer causes. And then we actually probably see more of this than the 3% from that thing, because COVID induced a thyroiditis in a lot of patients. And it's a classic de Quervain's picture where they have usually a viral upper respiratory tract infection. They felt hyperkinetic, a bit tremulous, energetic, a bit manic. And then they felt all right briefly, and then everything slowed down. So they become overactive. They pour out all the preformed thyroid hormone and are then underactive and usually become euthyroid over time. Although some patients who are TPO antibody positive, who were primed to get Hashimoto's, they can remain hypothyroid. And then drug-induced thyroiditis. So amiodarone is the one that we all know about, but there are a variety now of tyrosine kinase inhibitors and a plethora of immune checkpoint inhibitors that can cause thyroid disease and pituitary disease and diabetes, etc. I can't pronounce many of them. So yeah, keep it really simple. Antibodies and then an uptake scan. So there are many things that we understand in life. And the Liz Truss budget's not one of them. And the fact that antibodies can be blocking or stimulating is also one of them too. So thyroid receptor antibodies are almost always stimulating. But it was first recognized as late hypothyroidism with Graves' disease. Things we never learned at medical school. So when I first saw my first case with someone who'd had Graves, it was treated and then became hypothyroid, I was like, my gosh, this was 2007. So I looked up the literature. Right enough, there were case reports of late hypothyroidism following Graves' disease. And right enough, now we can check thyroid receptor antibodies in every centre, and they come back quickly. We do know that patients, and it's a small number, but it's significant. So there was 4 out of 440 in one cohort recently who had Graves' disease, who developed late hypothyroidism. It's useful for me because I can say, listen, I can discharge you now. I'm satisfied with your thyroid receptor antibodies and your thyroid function test. You've had long enough on your antithyroid drugs. I used to always say, if anything happened the way it did when you first presented, attend your practice nurse, get some thyroid function tests done. If it is your thyroid, then the GP can send in a letter and I can see you in 2 weeks. But I now say, I now add to that, and in the rare occasion you find yourself that you're putting on weight, your eyebrows are decimated, and you're constipated and cold, then also get a set of thyroid function tests done too. We also do annual thyroid function tests in the cohort of patients contained, so type 1 diabetes, Addison's, trisomy 21, and also Turner's, because they've got a higher risk of thyroid disease. And then the thing also is quite often, so GPs order bloods differently, and there's a panel in which one you choose. Quite often they'll do TFTs and TPO antibodies together. The TFTs are normal, but the TPO antibodies are positive, and they say, well, what should we do now? And then they do have an 8-fold increased risk of hypothyroidism over the subsequent 20 years. It doesn't mean that they will become hypothyroid, and it certainly doesn't mean that giving them levothyroxine is going to help at that point. So I usually recommend annual thyroid function tests and TFTs if your symptoms change or progress. So these are, you'll have seen loads of these. So that's a grave, so background black, a uniform uptake that's bright. There's a solitary toxic nodule, a multinodular goiter, and that's what destructive thyroiditis looks like. Antibody negative graves, 1 to 5%, probably less now that the antibody technique's much better. We can pass that. So these are all the rare things that you get with Graves' disease. So orbitopathy and Kevin Crofts coming later on. This is pre-tibial myxedema, which in this case had progressed. And this is the really rare thing called thyroid acropatchy, which is when you get periosteal reactions and clubbing. So we see these things rarely. But we do far more often see things like the borderline calcium that I've shown you before, and a slightly elevated ALP, neutropenia, which is very relevant, and microcystic anemia, which are far more common. So how do we treat it? So as I mentioned, the fact there's 2 drugs that we use, carbimazole and propylthiouracil, or we can use radioactive iodine. So I'll go on to talk about both those things, and things that and how things have changed slightly. So carbimazole is actually a prodrug. Patients who've come from different countries will be on methimazole, and which is cleaved and converted by a liver first pass. And it's a drug of choice because the side effect profile is much better. So 40% of people with carbimazole get some side effects. It's usually skin dyscrasias, itchy, some GI upset, versus half of people in propylthiouracil. If someone's intolerant of carbimazole, I'm usually surprised, and it's probably been something else. But if we are converting them over, 10 milligrams of carbimazole, so 5 milligrams of carbimazole is the same as 50 milligrams of PTU, or 10 is the same as 100. So we can convert the dose. If someone wishes to become pregnant and they're thyrotoxic, so if they're thyrotoxic per se, there's a higher risk of miscarriage. So we always advise them to use contraception until they're euthyroid. But if someone's desperate to have children, then having Graves' disease isn't a contraindication. We change them over to PTU. So we don't use PTU we don't use carbimazole in the first trimester of pregnancy because it can cause something called aplesia cutis, which is a scalp defect. And then after the first trimester, we change them onto carbimazole because propylthiouracil can cause fulminant hepatic failure. Usually in pregnancy, we can get their dose down and stop it. So remember, your autoimmune profile changes during pregnancy because you're carrying 1 or 2 other children. And so we can normally stop antithyroid drugs during pregnancy and then wait for the inevitable 6-week relapse afterwards. I think if you were to choose a time to be thyrotoxic, postpartum is that time. So some interesting things. So I've left this on the slide. So when you read textbooks, you'll see that younger patients with large goiters, high presentation T3 and smokers, and very high TRAb levels are the ones that are least likely to remain in remission. And that really tailored the conversation that you had with patients at the onset when you say, well, listen, there are a number of options here. We're going to give you antithyroid drugs to render you euthyroid anyway. But actually, and there's a scoring system I'll show you called the GREAT score that we use quite a lot. You know, you're male, you're young, you know, your presentation T3 is over 9. And your thyroid receptor antibodies are heroic. So I think that you're someone who is inevitably going to relapse after 18 months of treatment, and we should be thinking about a definitive therapy at that point. And the problem with radioactive iodine are the social preclusions. So I'll get to that in about 2 minutes' time. So if you've got preschool children, then you can't be in cuddling contact for 3 weeks. So for young mums, having radioactive iodine is impossible, and if they think, well, the medication's not going to work, then that's when they end up almost being shunted towards thyroidectomy, whereas I think that's probably the wrong thing to do now. And then beta blockers in small doses. And I always tell people, and you can use this if you want, if you ever need to, propranolol prevents symptoms. So when you forget to take it, you can stop it, but it's the carbimazole that cures. But other really pertinent things are that, so we worry about agranulocytosis, but it's rare. So between 0.5 and 0.1 and 0.5%. Recent meta-analysis showed 0.2%, so uncommon. Older guidelines used to say you do a baseline full blood count. All the modern guidelines say don't do it, because you're going to find out that the white count's below 4 because they're thyrotoxic. They're actually incredibly well tolerated. So 97% of all adverse events will happen by 6 months. So if someone's been on them for 6 months and they've been okay, they're going to be okay on them for a long time. And the problem is you get an endocrinologist at the outset saying, well, we'll give you these medications for 12 to 18 months. The patient's like, that long? Whereas what we should be saying is actually, we're going to give you these medications possibly for years until your thyroid's controlled and your antibody levels are undetectable. So the patient expectations set, so they don't get really, when at month 18, when they stop it, and then it comes back at month 20, they're like, right, I need something done about this now. And the two options are radioactive iodine, but actually if they've got young kids at home, which is for a lot of these people because they are young, is why they get frustrated. Some of these, so I put the most common side effects up. Carbimazole has been recognised to cause pancreatitis, but not substantiated. There's an ANCA-negative vasculitis also recognised with PTU. And the main issue is with PTU is liver damage, which occurs in 0.1%, which is again uncommon, but more common in children. So they're very well tolerated medications. So this is a great score that I was talking about that we used to use to govern our discussions. So it uses a combination of age, your thyroid biochemistry, antibody status, and goiter to put you in either one of 4 groups. But you can see for a lot of people quite quickly, they fall into this group where they've got a low recurrence rate, but actually, if you're younger, you've got toxic biochemistry, then you end up being in the high recurrence rate. But this was only a 24-month follow-up trial, which has been somewhat surpassed. So old-fashioned treatment, and the textbooks will say 12 to 18 months of antithyroid drugs, but the remission rate was basically, you can toss a coin, you've got a 1 in 2 chance of remaining in remission. So there was 2 papers by a single centre, and I put the publication journals below, but I'll summarise it. So they looked at giving, it was a randomised controlled trial, but not blinded, and they gave either 18 to 24 months of treatment or 60 to 120 months of treatment. And the recurrence rate was, again, 53% in the shorter course, but in the longer course, 15%. So that blows the last slide right out of the water. And that was all comers. So that was regardless of your presentation T3 or your thyroid receptor antibody levels or your enormous goiter. And then there was a paper published at the end of April, and it looked at this cohort that they'd done the first trial in and followed them up for 84 months, had found that 4 of them had become hypothyroid, the late hypothyroidism. But the remission rates remained for the long-term treatment 83%, whereas for the shorter term it was 44%. So, categorically giving a longer treatment duration with antithyroid drugs. And for how long? So the 2 things that they'd done was to make sure that your thyroid receptor antibodies were undetectable. And there's good data that show that after 5 years of treatment, they stop fluctuating and remain stable and don't come back. And then looking at your TSH. So if your TSH level was in the normal reference range, i.e. not suppressed, so you're not overcoming the negative feedback, and your thyroid receptor antibodies are undetectable, then that's when you can stop antithyroid drugs. Interestingly, there's a paragraph in the paper about patients who were euthyroid and their thyroid receptor antibodies were also undetectable, but they're still so scared of becoming hyperthyroid again that they elected to carry on for another 6 to 12 months. So I now tell patients when they come up to clinic, and I've done since 2020, when this paper was first presented at the American Endocrine Conference, and say, you'll be coming back to my clinic for maybe years. And unless you develop any complications, then we don't need to rush towards radioactive iodine or surgery. However, if patients will say, listen, my life's hectic, I'm missing tablets, I'm becoming toxic again, I really want a definitive treatment. Or if they've got a toxic adenoma or multinodular goiter, then I do send them for radioactive iodine. I used to do that myself. It's quite a strict protocol. You get some iodine that's radio labeled. You can either do it in two different ways. You can use a 400, 600, or 800, whether or not it's a Graves, toxic, or multinodular goiter, or they've failed on an earlier treatment. You have to make them swallow the capsule and then escort them out of the hospital. So we used to do 2 a day at a time. I work in a centre where we do a calculated dose based on thyroid gland weight and percentage of uptake. That is to try and minimise treatment failure and also minimise post-radioactive hypothyroidism, which I tell patients is almost inevitable and can occur 6 to 18 months after treatment. They can reduce goiter volume by 60% in patients with multinodular goiter. We give them antithyroid drugs first to render them euthyroid. You can get transient thyroiditis afterwards, so that can exacerbate your thyrotoxicosis. So we warn them about that. Sometimes they get a sore throat, but it's a paracetamol sore throat. It's nothing more complicated than that. Most patients are completely unaware of it and just know that they feel better. And we rarely have to restart antithyroid drugs afterwards. Obviously, we avoid in patients who've got severe thyroid eye disease. If they've got moderate, then we cover them with corticosteroids, and it's contraindicated in pregnancy and breastfeeding. Having said all that, it's the social preclusions that are the most complex for them. So 3 weeks for preschool kids, 2 weeks for school-aged kids, and 1 week for adults. Kurdish guy, young kids, had a camper van, put it in his driveway, fitted it with an Xbox and a fridge, told his wife that I'd told him to do that. I'm just waiting to be named in the divorce papers. So it can be done. There's reported cases of risks of increased solid cancer mortality in radioactive iodine, and that's always mentioned, but has never been substantiated. So, I mean, people use different phrases like, well, it's less radiation than actually living in Aberdeen. But it's a really easy treatment, really high success. Post-radioactive iodine hypothyroidism is easy to treat. Are you talking about thyroid storm? Okay, I'll slip by these ones then. Amiodarone, it's named the wrong way around. So type 1 should be the common one, type 2 should be the rare one. So type 1 is the primed thyroid. So you've got antibodies before you get amiodarone. They get positive antibody levels, and you treat them with antithyroid drugs. Type 2 is far more common. It's due to the iodine content of amiodarone. Can happen at any point during treatment. Patients are usually on amiodarone for a very good reason, and it responds really quickly to corticosteroids. So older textbooks said that what you used to do was you used to measure the TFTs, start both, and if your T3's fallen by half, over 2 weeks you can stop the carbimazole because it's the prednisolone that's causing effect. But it's quite straightforward to look after as well. One slide on hyperthyroidism. So if someone's post-operative, how much do you start them on? So the weight designated dose, it always works. So it's 1.4 to 1.6 micrograms per kilogram per day. We quite often get referred patients whose TSH doesn't quite normalize on that. And so I weigh them, think about malabsorption. You can do a weekly dosing for a thyroid absorption protocol. But often the most important thing is to look at the other medication they're on. So there are obviously enzyme inducers, can increase the metabolism of levothyroxine, but iron, calcium salts, and omeprazole are the biggest culprits. So when I start someone on levothyroxine, I tell them to take the tablet when you're not taking anything else, when you brush your teeth, and if you fall pregnant, then to increase the dose by 25 micrograms. So the usual thyroid gland will augment its production of thyroid hormone by 30% in pregnancy. So we're just mimicking that by giving levothyroxine. But otherwise, it's just a hormone. So I thought you'd find the dosing and the drugs useful as surgeons who are sending patients back home with their thyroid glands being removed, and they're going to require lifelong levothyroxine. So this is a guy who had. So he speaks about me in his podcast occasionally. So I'm allowed to show, and he's given me permission to show slides. But this kind of shows a few of the things that I've talked about. So this is Jim Hamilton, who played rugby for Gloucester, Edinburgh, and he was playing for Saracens at the time. And he'd frozen, literally frozen, during a European Cup semi-final, and had to be taken off. enormous guy. I mean, he's about 6'8". He had 4 children, including twins that were less than 1. He does a rugby podcast every week called The Rugby Pod, and he's doing a live show in Edinburgh soon, and he's hilarious. His wife said, "You've got a body like a melted wheelie bin," when she saw him in the bathroom one morning. Thanks, darling. And right enough, he'd lost a lot of weight. His boxing weight to play second row for Scotland and Saracens was 124 kilograms. And the strength and conditioning at Saracens had been on him. You know, you're not following your diet, you're not eating enough, you're not doing enough weights. His 6 foot was huge. He's a quarter Chinese, which probably explains the periodic paralysis in the semi-final. He had gone to Harley Street and had seen an endocrinologist there, and couldn't really understand what he'd been told. So he'd asked one of the Scotland doctors, Johnny Hansen, if he knew an endocrinologist in Scotland that he could see, who could explain things in normal language. And Johnny said, "I know just the guy." So he flew up to Stobhill to see me. The nurses formed an orderly queue to take his bloods, and he brought caps for them all, etc. I don't do any private work, but and he said, "Well, you know, you can charge whatever you want to." And I said, "Well, I can't charge anything because I'm not insured." So he had a moderate goiter, enormous trabs, high presentation T3, and I really struggled to get him euthyroid. He's really funny. So he was on the appropriate dose of antithyroid medication. He's at the Hong Kong Sevens. He was at the British Lions tour. He commentates on rugby. He does a lot of stuff for the media. And so I was convinced he was missing tablets. And he used to say, "Look, I swear on my Graves' disease, I never miss any of my tablets." But he was chaotic. So that's Big Jim there. So yeah, he came back for a pint in my house because he had some time. A lovely guy, and then he flew back down to London. But he used to come up and see me in Stobhill, and he then moved to Edinburgh. And so obviously there's an endocrinologist in Edinburgh. So I referred him to Fraser Gibb and Stuart Ritchie. I think it was Stuart Ritchie who saw him, and his TFTs had never stabilised, so he had a thyroidectomy, which has been very successful. So he's then on levothyroxine, and he was on the appropriate dose for a man of his size, but his TFTs, his TSH was always elevated. And he also felt a bit tired, a bit fatigued. So he then messaged me to say, "Cut out wheat, bread, pasta, and cereals, feeling a lot better." And I've been to my GP, and it was right. I've got celiac disease. So if I was looking after Jim again now, I would have suggested a much longer duration of antithyroid drugs. He says that he didn't have the same problem with bread, wheat, and etc. when I was looking after him, but I think it's just been nice. But he didn't have current celiac disease, so doctors who never tell you any of their complaints in a talk haven't missed things. But the take-home messages are that if you get referred to someone and they've had a short duration of antithyroid drugs, as a surgeon, it's entirely reasonable to say, "I can do a thyroidectomy," but actually, current practice is to give up to and around 5 years if required, until your thyroid receptor antibodies are undetectable. So before we go ahead, do you want to think about that? And if they're adamant and they have issues in and around radioactive iodine, so Omar and I have people that have been referred to him that he sent back, that he sent back to say that actually, no, I've talked about radioactive iodine, that's what they want now. If you're giving someone levothyroxine and you're telling your FY1 or FY2 what dose to say, 1.5 micrograms per kilogram, so they can weigh them and send them home on the right dose. And if they're female, if they fall pregnant, they increase the dose by 25 micrograms. But it's been a huge change in thyroid practice. So I've gone from, so this is my 4th time, I've gone from telling people 12 to 18 months to now saying you'll be here for probably around 5 years. And it might be a bit shorter, and it might be a bit longer, but this is a long-term medication. And if you see them back at 6 months and they've got no side effects, you know that they fall into 97% of people who won't. So the presentation at the American Endocrine Conference finished by saying that you should tell patients with Graves' disease that think of it as having hypertension. I mean, no one ever says, "When starting ramipril and in 18 months' time, unless you've lost weight and become fit, then you'll stop it." It's always like, well, we're giving this long-term treatment which benefits your heart and your kidneys, etc. So I'll take any questions, and thanks very much for listening.
Russell, thank you very much. Now, I won't do questions.